Hello, everyone, and welcome to the Shelbourne Knee Center podcast. My name is Rodney Benner. I'm an orthopedic surgeon at the Shelbourne Knee Center in Indianapolis, Indiana, and this is the inaugural episode of the Shelbourne Knee Center podcast. We're going to talk about all things knees, and this is directed towards clinicians treating knee problems. My co-host is Scott Bauman. Scott, thank you for joining us tonight.
It's good to be here. We're excited to get started. We do have a lot of topics coming up, and as Dr. Benner will talk about, this topic tonight is going to be about interdisciplinary care in orthopedics.
That's right. We have a very interdisciplinary clinic at Shelbourne Knee Center. We'll go into a lot of details about that and some other places where it may be available in orthopedics and what we think are some advantages and disadvantages of that kind of a setup. If you'd like to find the Shelbourne Knee Center podcast, you can find it wherever you get your podcasts. You can also find us on our social media channels at the Shelbourne Knee Center podcast on Facebook and as well on Twitter and Instagram with the handle at the SKC podcast. That's SKCPODCAST, or you can email us if you'd like to get in touch with us at the skcpodcast@gmail.com. You can also find these details inside the podcast app in our show notes. Scott, we're getting started tonight talking about an interdisciplinary approach in orthopedics, and we're going to talk about what those component parts are specifically at our office and how they are utilized and other spots in orthopedics as well. And it's a topic that is really special to us because we utilize it in our office and we think that that's what really makes us special and different.
Yeah, and I guess right off the bat, everybody here has a good understanding of what interdisciplinary care is, but especially with orthopedics, I want to talk a little bit about why this is an important topic as it pertains to the clinician and both the as well as the patient. So discuss a little bit about why this model is important and why it can be important for patients and clinicians.
Well, I think it's important for a lot of different reasons. One is just that direct interaction that we have amongst the different types of healthcare professionals within our clinic. Having experience during training at other places, I don't know that we necessarily had that in quite as good of a place, in good of a way, even though I felt I was happy with the training I got at those places and the care we were able to provide. There was always a couple of layers that made it a little bit difficult from a communication perspective. So having everybody in the same office is something that that I think is really different. And also just being able to interact with different points of view, getting different points of view on how to take care of knee problems from not just the physicians, but also other allied health professionals as well, has been really important.
Yeah, I think that's an important note. You know, when you mentioned training, when I was applying to physical therapy schools way back in the day, I got into a program up in Chicago that the first year of physical therapy school, you took classes with the medical students, and it was your basic sciences. It was anatomy, physiology, those types of things. And obviously you're going to divert quite a bit with, the medical students going on to different types of education versus the physical therapy students. But looking back, I thought it was an important aspect. And the key that the program heads wanted to attain with that was just initializing that communication between those two professions. And not that you're necessarily going to bounce ideas off each other in first year of medical school and first year of PT school, but I think it does go a long way in terms of really laying the groundwork for that communication between the two professionals. Because as you know, interdisciplinary care that's what it's all about, is trying to get the best of both worlds with multi-professionals.
For orthopedic surgeons in particular, I think we're just really focused on how to do the surgery better. How do I get the operation done? How do I get the fracture fixed? How do I get the alignment correct? And then the rehabilitation portion of it really seems like somebody else's job, somebody else's problem. When you're training, you feel that way anyway. Once you get out into practice, you realize that is not at all the case, and that all of a sudden people are asking you what kind of post-op protocols you have. I remember as a trainee, the answer was, we'll do whatever the attending wants to do, and that's their protocol. And then afterwards, when I got into practice, all of a sudden people were asking that of me, and I'm like, well, go ahead, go ask the attending. They're like, that's you, dude. So, it was a different thing to have to come up with those kind of protocols myself, and to have that direct connection with the therapist to understand what they're doing on a daily basis, and vice versa, have them understand the operation that I did, how I did it. For example, what kind of ACL graft I used, what kind of knee replacement prosthesis I used, why we're doing a revision surgery in one patient versus another. I think is an essential way for us to be able to learn from each other and incorporate those multidisciplinary approaches in our respective respective areas of study and areas of focus.
Sure. And I completely agree with that. And in terms of settings, one of the best models that I think of when it comes to interdisciplinary care within medicine has been the sports model. And that is, talking about a sports medicine team where you look at the team doc or the surgeon is really the head of that team, but it really goes in an umbrella fashion underneath that, where you have a lot of different professions: physical therapists, athletic trainers, strength coaches, position coaches, head coaches, and also include the athlete in that. But, talk a little bit about your experience within the sports medicine field as it pertains to interdisciplinary care.
It's been a pretty wide breadth of experiences, just because of the different types of athletic settings that I've been able to provide team physician coverage to. I take care of a high school here in the Indianapolis area. I also take care of Wabash College, which is a Division III school. I also, for 10 years, was an orthopedic consultant for Purdue University at the Division I level in the Big Ten. So as you can imagine, the amount of resources, the amount of different disciplines that play into the kind of overall team approach to sports medicine care is pretty variable. At the high school level, it's me and one athletic trainer on the football sideline on Friday nights. So there's a lot more, I'm covering the field while he's tending to an athlete or vice versa. And we're the only ones there. There's EMTs there with the ambulance as well, but a lot smaller scale at the high school level. At the Division III level, it's one, maybe two athletic trainers. We also have two primary care physicians that are on the sidelines with us as well to help spread out that workload and be a little more compartmentalized, dealing with either medical conditions, concussions, things like that, versus orthopedic bone and joint conditions that I take care of. And then at Purdue, it's a completely different level where we have a head athletic trainer. Our director of sports medicine was on the sideline. We have an offensive and defensive focused athletic trainer. And then we have multiple student trainers, graduate students, undergraduate students. We also have our team physicians that are our either primary care sports medicine, or in our case, it was a physical medicine rehabilitation specialist that is a specialist in sports medicine as well. And then two of us orthopedic surgeons on the sideline, one more in touch with upper extremity injuries, me more in touch with lower extremity injuries, and then EMTs on site as well. So a much wider breadth of specialists. And you even mentioned, especially at the Division I level, but also at the Division III level, position coaches, coordinators, head coach, even media, which I didn't really have to interact with. But the interesting thing would be when things would pop up in the media and you'd read about somebody's injury or on message boards, and all of a sudden you're going, where'd they get that information? That's not even right. So that was always interesting, reading about injuries that came out different ways when it was in the media. But the point is that
Twitter and Instagram on those medias.
Everything counts, right? So So, all those disciplines played into it in the sports medicine model. And I think that's a lot of orthopedic practitioners in particular that have been a part of that can really see the value in that. And I think to spin that back to the multidisciplinary approach when it comes to an orthopedic office, I don't think a sports medicine provider would ever want to go onto the field to take care of a Division I sport, of a Division I football team, for example, with one athletic trainer and one surgeon in the way that we do on the high school sideline. There's no way that would ever be acceptable at the Division I level. For me, it would never be acceptable in my office to go to see patients without physical therapy, without athletic training, without my PA, and all those people kind of working together. So in the same way that we hold ourselves to that high standard when it comes to sports medicine, we at the Shelbourne Knee Center like to say, let's hold ourselves to that same multidisciplinary high standard in the office as well.
Yeah, and I'll go one step further. I'm glad you said multidisciplinary, because I do feel like those two terms, interdisciplinary and multidisciplinary, get interchanged. And I like to think there's a true designation between the two. Multidisciplinary I see as different professions working in parallel, where you have the surgeon treating the medical orthopedic side of things, for example, with the orthopedic surgeons, the physical therapists, for lack of a better term, staying in their lane on the rehab, athletic training doing the same. And they talk to each other, and you're treating in these multidisciplines, which is great. I like to think of it as truly interdisciplinary care, where you're bouncing things off of each other and you're working together as opposed to side by side. And do you see that happening in the sports medicine side when you're talking about this particular model?
Absolutely, in the sports medicine realm, and also in the way we run our office, and that's I know we're going to talk about a little bit later on how we run our office at Shelbourne Knee Center. With the approach with the teams, if somebody has a hamstring strain, I'm going to examine them to see how bad I think the hamstring is, how what grade I think it is, whether or not we need imaging, whether or not I think it's safe for the athlete to return to play. And then I'm going to let the athletic trainer and physical therapist ultimately do what they're good at, do what they are trained on. I don't tell them exactly what exercises to do, what stretches to do. They know that themselves. I handle the part that I handle and they handle theirs, but we all do it together. And the communication is always a big piece of that as well.
Mm-hmm. Yeah, that's a good segue into talking about our office. One quick story Dr. Shelbourne always likes to tell us in the clinic is when he was just starting with Purdue back in the early to mid 80s, and he would examine somebody's knee, let's say it was an ACL tear, do the surgery, and then, write them off to physical therapy or athletic training, whoever's taking care of the athlete. And the head athletic trainer at the time came back to Dr. Shelbourne and says, well, what do you want me to do? And he says, I don't know. You're the athletic trainer. Do training, do therapy. Mm-hmm. He says, well, we need your direction. And they kind of both looked at each other, kind of dumbfounded, thinking, well, we don't really know what each other does at this point. And that was really an eye-opening moment for Dr. Shelbourne back in the day to say, well, why are we treating these patients separately? Why don't we treat them together? And that's really where a lot of this model started. Where the athletic trainer knew exactly what Dr. Shelbourne was doing from a surgical and a medical perspective, and vice versa. Dr. Shelbourne had the opportunity to see what therapy was doing in order to better his practice.
Yeah, so our practice at Shelbourne Knee Center, Scott, as you know, but for our listeners to learn about, it really integrates three main levels of care. One being the surgeons/clinicians. We have two surgeons and a physician's assistant in our office who are the kind of providers in the clinic. And then we have the physical therapy staff that works in the clinic as well. They work really as physician extenders to a large degree in that if you come to and athletic trainers as well, we have one athletic trainer as well in our office. If you come to my office to see me for a new patient visit, it's a physical therapist that goes out to the waiting room and calls you back. Once you get back to the room, they're getting that initial history, getting that initial physical exam, and coming up with a provisional diagnosis. We also have X-ray in the office as well. The therapist then walks them down, gets them ready for their X-ray, which is done by X-ray technicians that do nothing but knees. So we get really good imaging in our office for that reason. The therapist then puts them back in a room and then comes and puts them on my list and presents them to me, kind of like you would with a PA, a nurse practitioner, a resident, whoever else is helping you work up patients in the clinic. And then before we go in the room, we have a provisional diagnosis. We're all kind of on the same page of what the patient's told us, and then we go in the room and see the patient together. And the nice thing about seeing the patient together is we have that direct communication between myself, the therapist, and also the patient and family members as well. As I'm sure everyone listening to this has had the experience of at some point. Sometimes you come out of the room and the therapist then you send the patient to therapy and they call you and said, hey, this patient says, or the patient's family say that you said this. And you shake your head like, no, I did not say that. I said this. Oh, okay. Well, that makes sense. We don't have to worry about that when we have them in the office with us. And we can also talk about X-ray findings, educate the patient, educate the therapist on what we found, and directly start that therapy process right away. I then, once we've answered questions and everything, discuss the diagnosis, I leave the room, and the therapist then takes over and begins their treatment. From that point moving forward, the therapist is their direct contact at our office. If they have a question about something they heard, my front desk will put them through to the therapist. The therapist can usually answer the question. If they can't, they know to get in touch with one of us as the physicians to try to get clarification of whatever they need. But that's their person then moving forward throughout their treatment plan. And I think that's really important from the therapist perspective to get in touch with the patient early on after when they first come into the office, to generate a relationship with them, to be kind of with them throughout that entire process. So I guess I'll ask this back to you, Scott, from your experience as being a therapist in our office. How did that differ from your previous employment where you didn't have that kind of setup? And what did you think were some specific advantages about it?
From a setup standpoint, it's completely night and day. Before I came on to the Shelbourne Knee Center as a physical therapist, I was at your general orthopedic outpatient clinic where you're seeing patients from many different referral sources with different philosophies of treatment. To get specific in terms of something like ACLs, you have 3 different ACL grafts you're treating, and it can get a little confusing, to be honest with you. And then if you have questions or patient's not doing well, or you want to alter treatment in some way and you want to get a hold of the surgeon, that can sometimes be a challenging task. Do you get them on the phone? Do you email them? Do you fax them? By the time somebody gets back to you, maybe the problem's not a problem anymore, or you decided to divert one way, whether you had the backing behind the surgeon or not, or what have you. And it's that communication aspect that I feel like is the biggest advantage. When you say, what's the advantage of working in a situation like this? I would say it's that communication piece with the surgeon, because again, you can divert treatment, you can alter treatment, you can ask questions why treatment is being done in a certain way. And that's all done being treated side by side with the surgeon. And again, that's just not something you see in your typical outpatient physical therapy setting.
That's one of the things that I like most about this approach, is that we have kind of a unified approach to treatment. We sometimes have patients tell us almost as a criticism that, you said the same thing that Scott said, or you said the same thing that Sarah said, or that Bill said when I asked them that same question. And they're almost annoyed by that like they'd almost rather, play gotcha with the therapist. Oh, I told you that the surgeon was going to say something different, and they kind of shake their head sometimes. But I think that's a big strength of the way we do things, is that if somebody asks you a question, if somebody asks one of our other therapists the question, my PA the question, or either of us as a surgeons, they're getting the same answer over and over and over again, and we're all on the same page on how we're treating patients collectively. So kind of talk about, or give any examples maybe if you've had before from previous employment on where that could potentially be a roadblock when you're not everybody is looking at things in exactly the same way.
It really is challenging, and not knowing why is really another big piece of this. So I get that script saying to do X, Y, Z with not a whole lot of conversation with the surgeon in terms of, okay, explain to me why you want this patient to be partial weight bearing, or tell me why you want this patient to be in a brace for 4 to 6 weeks. And another advantage of our office setup and where we're at now is that education piece. And you talked about when the patient asks a question and they're almost trying to trip you up, where, oh, Scott said this, but Dr. Benninger, I noticed you said the same thing. It kind of seems like they're almost trying to play you a little bit. And that education that we get as a therapist working with the surgeon is really unmatched. When we get students all the time in our clinic, and they're really blown away the first week of their rotation, because they just can't believe they have the opportunity to speak about surgical parameters and surgical techniques with an orthopedic surgeon, and how that directly impacts physical therapy, because that interaction just isn't taught in physical therapy school. You're taught certain modalities, certain treatment philosophies, and by the way, here's the surgical procedure that was done, and here's the options that could be done. But that link to here's the surgery and how it was done and how that changes rehab, or my biggest thing is it gives the why. If you have a certain type of graft being done for ACLs, here's why we don't limit weight bearing, or here's why we don't put them in a brace, and why we want them to work on range of motion quickly. And that is something you just don't get everywhere from a physical therapy standpoint.
Let's talk about that last leg of the multidisciplinary approach, in addition to the clinicians or the clinician providers, surgeons, and extenders, along with the physical therapy staff, and add in also the research staff. At Shelbourne Knee Center, we have Scott, who works as a data analyst, a medical writer, works a lot with our data, helps manage our database. We have a research director that handles a lot of our IRB submissions and keeping us in a good place from a regulatory perspective. And then we have a couple of clinical coordinators who are always sending out patient surveys to collect data long term, getting people back in for research visits, and also doing a lot of our consent procedures and things when we're enrolling patients into studies. So talk a little bit, Scott, about the inclusion and the integration of the research staff in our clinic, and how that helps lead to better patient outcomes.
Sure. And it's really intertwined throughout the entire continuum of care. And you just named 4 people in our office that are designated quote unquote research staff, but we also like to mention that everybody in our office is involved with research. And that could be study question development, or more than anything, data collection, because we collect data really on every patient at every visit, and whether for example, a therapist is working on a particular study or not, that data is going to be collected. So everybody has that integration from a research standpoint. But beyond that, and probably more importantly, the integration comes with that why. We talked about the surgeons having that conversation with the physical therapist in terms of here's why things are done the way they are. And the whether the therapist is saying things or whether the surgeon is saying things, those aren't statements that are made up or are done on a whim. They're all backed by data and by research. And you talk about everybody wants to have evidence-based treatment philosophies, and we really are, in my opinion, are the epitome of that, because every decision we make from a treatment standpoint, from a surgical technique standpoint, is really backed by research. And we've been collecting data on patients since 1982, and we continue to do it to this day. And when we see patients that fall into a pattern, which is, in my opinion, a nice thing about working in a specialty center, we see knees all day, every day. And good or bad, you see patterns in terms of people doing really well with certain types of things or maybe struggling with something. And that's a good opportunity to work with your research department and say, okay, I'm seeing this clinically. What type of research question can we develop to answer this, to hopefully model after the good things we're seeing, or maybe try to change things and try to get those patients that are quote unquote not doing as well on a better path. And we develop a study, we collect data, we answer that through the data, and eventually alter treatment. So we're always trying to improve upon things and get our outcomes to be better and better and better. And that cannot be done without the research staff that we have. So we've discussed for the past 30 minutes or so about how beneficial this type of model is. The question we typically get when we talk to whether it be medical students or physical therapy students is, yeah, on paper that sounds like a great model, but how do I as a clinician duplicate it?
Well, it's not easy to do. You and I have been able to benefit. I'm in 11 years at the Shelbourne Knee Center. How many has it been for you, Scott? Remind me.
It's getting close to 9.
8 or 9 years that you've been in this system as well. We've been lucky enough to be able to learn from Dr. Shelbourne and to be able to see the model come to fruition, and also and really flourish and be a part of it ourselves without having to set it up ourselves. But if you're trying to do this yourself, a couple things. One, you need a therapist as a surgeon, you need therapists you can trust and that you have a good relationship with. I think reaching out to those therapists, to invite them over to your clinic, to maybe spend some time to see exactly what you do and send them patients on a regular basis is a really big part of that. The communication piece is essential, as we've talked about, and that starts, in my opinion, with the surgeon, the clinician who's seeing the patient in the office, to not just send out a slip that says evaluate and treat, go find yourself a therapist, but to have a directed link to a therapy office. I think it's important for surgeons, whether you're going to set up an office like ours or not, to find therapists that you trust and that do a good job. So once you find a couple of those, get out into the community and reach out to them and say, you know what, I'm Dr. Benner. I have a knee practice that therapy is a very important part of. Is there a way to integrate your therapy practice? I've seen that you've done a good job with our previous patients. Could we work together on a more directly linked basis and be able to start feeding them patients? On the therapy side, I think it's really important for therapists to be able to get access to patients pre-surgery. That's something that we really stress. And I think, on the flip side, if you've never seen the patient before and they show up to you for post-op therapy from a surgery that you didn't know about beforehand, you don't know what they've done pre-op, you don't know what their preoperative or post-operative expectations are. It's really difficult, I got to imagine, for you to be able to take care of that versus if the patient is introduced to you pre-surgery, you generate a relationship with them and things like that. As well as a surgeon, it's got to be a lot easier. So therapists, if you're trying to get this kind of specialty practice, you want this kind of communication and integration that we're talking about. It's kind of the same as the surgeon. Reach out ahead of time, try to get a good relationship with the surgeon so they can send you patients. It's good for your bottom line and good for your volume, but it's also good to be able to provide that kind of integrated care that we're talking about. From a research perspective, it really starts with just the will to do it. not every surgeon really has the will to follow their patients quite as long as maybe people do at academic centers or other places where you do research. That's not necessarily a bad thing, but not everybody probably can do the kind of research that we're talking about. But if you're interested in it, just finding somebody who's interested in helping you along the way. Just start with something as simple as having your patients fill out a pre and post operative survey, and then look at your own results over time. Track your own complication rates, to figure out how often do I get infections, how often do I get patients that are stiff that I have to manipulate or have to do other procedures to, how often do I have patients get DVTs, where do I seem to be losing track of patients? What do I do that? And also very importantly, who are the patients that do really well? I think we focus in orthopedics a lot on who does poorly and how can we figure out how to avoid these poor outcomes. I don't think we do enough sometimes with saying who's really doing well and what are the factors that made them do so well and how do I replicate that as much as I can. So I really think if you want to try to set something like this up in your own practice, it's just about grinding your way towards it, getting a relationship with a therapist, getting a relationship with someone who wants to help to assist with research, and from the therapy side, getting in touch with the surgeon and tracking your own outcomes, as well as just having that direct link.
Yeah, two things on that. When you talk about developing this model or starting this system, keep in mind that it's a win-win situation. I'm sure a surgeon, Dr. Bennett, correct me if I'm wrong, I'm sure an orthopedic surgeon would love if a physical therapist came to him and said, you know what, let me see some of your patients preoperatively. I have some ways that can get these patients optimized for surgery, or, let's work together and really try to figure out these problems. Just having that initiative, I think, is great. And just keeping in mind that it's on both ends, it's going to be a win-win, and ultimately you're chasing better patient outcomes. And at the end of the day, I think everybody would agree that a good interdisciplinary care model is going to give you the best outcomes. And then the second thing with the research, I think you also hit a good point as well, learning from your good outcomes. When I talk to patients about, well, it seems really daunting to start collecting data, I say start small. Chase what you're passionate about. If you're in a general orthopedic center and you really enjoy and see a good volume of, for example, ACLs, like Dr. Benner was saying, take the best 10% and the worst 10%. You can learn a lot from those two ends of the spectrum, and track your outcomes, track your complications, track those both positive and negative outcomes, and try to learn as much as you can through any type of data collection you can come up with.
If you have any questions about this, you can find us via email at the skcpodcast@gmail.com. You can also find us on social media via Facebook, looking up the Shelbourne Knee Center podcast, or through Twitter and Instagram at the SKC podcast via those social media channels. Scott, this has been fun. Thank you for helping us complete our first episode.
Yes, thank you.
If you have any other questions, feel free to reach out to us. We'll be back with another topic in the near future. Thank you.